Welcome to our presentation today on restraint minimisation, and thank you for taking the time to join us. We'd just like to begin with an opening karakia. Kia hora te marino, kia whakapapa pounamu te moana. Hei huarahi mā tātou I te rangi nei, aroha atu, aroha mai, tātou ia tātou katoa, huie taekie. Kia ora everybody, I am Sarah and I am joined today by my colleague Pauline. We are clinical service advisors from Enable New Zealand. We are part of a team of experienced occupational therapists and physiotherapists. Our mission is to support disabled people and their whānau to live everyday lives in their communities. We aim to do this by effectively managing access to equipment and modifications on behalf of Whaikaha, Ministry of Disabled People, and ACC. So as I said, I'm Sarah. I'm a physiotherapist by background and have been working in paediatrics and special schools in the wider Auckland area over the past 15 years. I have been employed as a member of the Whaikaha advisory team with Enable New Zealand for the past 18 months. Pauline.
Hi, I'm Pauline. I'm a physiotherapist. I have a background of working in the hospitals community in New Zealand and the UK, and general, mainly adult areas of physiotherapy. I've been working for Enable for nearly 4 years, and I'm in the team, the Clinical Services Advisory team that look at the ACC equipment requests. Thanks, Sarah.
Thank you, Pauline. Next slide, please. So the intent of this presentation will be to help establish a consistent approach to providing safe and quality care in relation to tailored solutions that may limit a person's normal freedom of movement, and to highlight the parts of the current standard we expect are relevant to our practice. The objectives for today include to be aware of the most recent New Zealand standard concerning restraint, provide you with and highlight relevant resources, and highlight that some of our commonly prescribed equipment could be at times limiting a person's normal freedom of movement and the consideration that needs to be given to this. We started looking into this area as we noted inconsistencies when reviewing situations potentially involving restraint. This has led to us researching the current standards and considering how we apply them to our work. Next slide, please. So we are going to start with a quick activity. If you could just take a minute to consider some examples of equipment solutions that you have come across where you considered if the solution could be a restraint. Remember to apply context and scenario in your thinking, and in a minute or so, I will share an example. Thank you. So I am thinking of a tray. Adding a tray to a seating solution for additional positioning support or to improve use of functional skills can be a great solution for some people. But if that person can normally independently sit to stand and they are not able to release and remove that tray independently, have I now in fact restrained them? Maybe keep this example in mind as we keep moving through our slides, as we hope to highlight ways to clinically reason through proposed solutions with direction from the current standards and potentially flag things we may not all be currently considering. Next slide, please. And over to you, Pauline.
Health and Disability Services Standard. On the Manatū Holder Ministry of Health website, in a video by Dr. Ashley Bloomfield, he quotes, "This standard outlines what we can expect in New Zealand to ensure we provide high quality and safe health and disability services." It was published in 2021 and came into effect in February 2022. It applies to a wide range of providers, and certain providers are required to comply with the standard and are audited against relevant sections of the standard. For example, providers of overnight hospital inpatient services. Additionally, it notes it is also fit for use by home and community support services. Thus, I expect the standard relates to all of our work. One of the goals in this standard is for a restraint-free environment. Right, it's gone one slide further than what I expected. So the principles of the standard are documented on the slide, and there is more details in the document itself if you want to read into it. Next slide. Additionally, principles of Te Tiriti o Waitangi have been formative in developing this standard. And tino rangatiratanga can be translated as the right to self-govern. Next slide. Outcome 6 is the outcome that refers to restraint and seclusion. As per the slide, services shall aim for a restraint-free and seclusion-free environment in which people's dignity and mana are maintained. For outcome 6, the outcome statements in the next 3 slides are formatted in 3 columns. And from left to right, they talk to what all people can expect from the services and support they receive, what Māori can expect from the services and support they receive, and the commitment of service providers doing their part to deliver the best quality care and services. Outcome 6.1, He Tukanga Here, I have highlighted the following: ensuring the person is free from restrictions, Te Tiriti partnership to gain mana enhancing and least restrictive practices, and the aim being elimination. All right, 6.2 is what we're after next. Herena Homaru highlights the need to adapt when things change for that person, for example, via a reassessment or review for the person. It also highlights least restrictive options used first, partnership, restraint being a last resort, and consideration of alternatives. Over to you. Oh, no, sorry, we've got one more slide. It's jumped again. Outcome 6.3, Aratake Kainga o Herena, highlights sharing of restraint experiences and monitoring and review to influence, inform, and improve practice. Of note, we haven't talked to outcome 6.4 on seclusion in this presentation. Over to you, Sarah.
Thank you, Pauline. We would like to highlight the following definitions from this current standard. Restraint. When assessing a person for a solution, we must always consider, does this limit the person's normal freedom of movement in all clinical reasoning? Restraint elimination. Thorough assessment is key to restraint elimination, and I'll talk to this in a later slide. Restraint episode. Elimination is the goal as per the current standards. However, it is acknowledged that this will not always be possible. If elimination is not possible, consideration and documentation of all other considered options is essential to ensure the solution in place is in fact the least restrictive. Next slide, please. So, what is normal freedom of movement? A pelvic positioning belt on a person who is unable to sit to stand independently without it does not limit their normal freedom of movement. The same solution on a person who normally can sit to stand independently and does not have the fine motor skills to release the belt does have their normal freedom of movement limited by this solution. It is not the equipment, but the individual person's functional ability that determines if a piece of equipment, often intended for safety or support, has also become a restraint to that person. We will work through some other examples together shortly. Next slide, please. So, how do we incorporate these current standards into our everyday clinical reasoning? This is a resource we have developed to help us work through individual cases, ensuring the current standards are considered and the least restrictive option is being used. There is a copy of the resource at the end of this presentation with a link for you to find. We would like to take a couple of minutes to talk through this, and then we'll work through some examples. So, thorough assessment is key to a restraint elimination. But what does this look like? It needs to be person-centered, open corridor with the person, family and whānau, other specialists, and with those involved in supporting that person. Functional abilities need to be assessed. What can the person do independently, and what can they achieve with assistance? Has the bigger picture been taken into account, including cultural considerations and both social and environmental factors, such as medications, mental health or emotional state, or the general physical setup of that person's space? Once we have all of that information and a solution in mind, we now ask the question, does the proposed solution have the potential to limit this person's normal freedom of movement? If no, run with it and document as per normal. If yes, the following needs to be considered. What is that person's normal functional ability? Could another option meet the need that doesn't limit normal freedom of movement? What else has been considered? Sometimes equipment solutions are not actually needed. What has been discounted and why? Remember, least restrictive options are to be used in the first instance. Who else may need to be involved? Have you peer reviewed the situation with a colleague or with a clinical advisor? Elimination is the goal as per the current standards. However, it is acknowledged that this will not always be possible. So at this point, if a solution that does limit a person's normal freedom of movement is deemed essential after thorough assessment and all other options considered and discounted, then that is called a restraint episode. If a restraint episode is indicated, there must be clear documentation to support the clinical reasoning around this decision and a review date scheduled so that our solutions adapt and change as people and their situations adapt and change. Sometimes restraint episodes are needed. That is okay. Our job is to keep people safe. However, safety is not the only consideration. Thinking back to the activity we did at the beginning of this presentation, these are solutions we had highlighted that we see coming through our service a lot, and I'll just give you a quick minute to read through them. All of these are examples of equipment that are often used to keep a person safe, aligned, or well positioned. However, it needs to be considered if it may also contribute to a restraint episode. This is where the flowchart can be a helpful resource in guiding our thinking around this, with the first thought being, will the addition of this solution limit this person's normal freedom of movement? As highlighted earlier, the answer to this question is dependent on that particular person's normal, independent, functional ability. Whether something does limit someone's normal freedom of movement is not always obvious at first glance, and this is where peer review alongside your clinical analysis is really helpful, and potentially the use of the flow chart we have just shared. Next slide, please, Pauline. Okay, so let's look at this scenario using the flow chart. Again, I'll just give you a quick minute to read the orange highlighted box of the slide. So after a thorough assessment, the solution of a safety sleep wrap was proposed. And if we reference the flow chart, we ask the question, does the solution limit normal freedom of movement? What is this child's normal functional ability? Can they normally transfer out of bed? Do they normally have independent bed mobility? The answer in this case was no. So the addition of the safety sleep wrap does not limit them from doing something they would normally be able to do. Least restrictive options first. Padded bedsides were considered and trialled in the first instance, however, were not successful in resolving the presenting issues. Who to involve? This solution has not come about as a result of challenging behaviour. Therefore, NASC, the Needs Assessment Service Coordination, and Explore input is not required if you are working within Whaikaha criteria. It was indicated that a peer review took place and the child's family and wider therapy team were involved. In this particular case, the solution proposed was deemed the most successful, least restrictive option, allowing for some movement but not extreme ranges to support safe positioning and the essential function of sleep for this person. In this case, the main question, does the solution limit the person's normal freedom of movement, made us think of movement in two different ways, posing the following questions for our further thinking. Is involuntary movement considered normal? And is involuntary movement normal for that person? As you know, these questions can only be considered on an individualised case-by-case basis for the person in question. No two people and their situation are the same. Next slide, please.
So picking up a second scenario, we can use the flowchart to help work through this also. So just take a little bit of time to read through the information. So in regards to assessment, we need to understand the recent history and why this person is wanting bed rails. Has something changed for them, i.e. a change in medication, environment, or their carers? We could involve whānau, carers, and the wider interdisciplinary team. We need to know whether they have episodes of confusion or memory problems. Might they attempt to climb over the rails, the bed rails, and have a risk of falling from a greater height? We would also assess their bed mobility and their ability to transfer out of bed independently. If they can transfer independently, rails would limit their normal freedom of movement and therefore would be considered a restraint. To consider least restrictive options first, is an equipment solution needed at all, or is there something else that needs to happen first? For example, a medication review. In regards to equipment, other least restrictive options could be a call bell or an intercom to call for assistance, sensor pads, a side support rail, i.e. just a small rail to assist with bed mobility and transfers rather than a full length rail, a wider bed, ultra low beds, which go lower to the floor than your average beds, and mattresses on the floor for people to fall onto as such if they do move out of that ultra-low bed. It is really important in your assessments and your reports, in your reports to note the considered and discounted options. Next slide, and back to Sarah.
Thank you, Pauline. We just wanted to take a minute to make some whaikaha specific points. Firstly, we acknowledge the language in EMS and NAS documents hasn't been updated to reflect the current language being used. In these documents, you will still see the word enabler, which is not referenced in the current standards. There is a table as part of the 2015 NASC interface document that clearly states what solutions are considered restraint and which pathway must be followed when challenging behaviour has been identified. As an EMS assessor working with people with challenging behaviour, you will need to be aware of this. If a solution has been identified as a restraint and challenging behaviour is in play, then consultation with the NASC is mandatory. The NASC will determine if a referral to explore is appropriate. At the yes box at the end of our flowchart, if accessing the whaikaha funding stream and challenging behaviour has been identified, you will need to consult with the NASC at this point. Consultation must take place before funding can be approved for any solution. And I'm just going to hand over to Pauline to add a comment for our ACC assessors.
And so for ACC assessors, if the proposed equipment is to help managing challenging behaviour, consultation with ACC Behavioural Support Services is recommended to consider least restrictive options first. For example, a behaviour strategy put in place rather than an equipment solution that is a restraint. And the behavioural support services will indicate the solutions that they support.
Thank you, Pauline. Next slide, please.
So take-home points from our presentation today. Whether an intervention limits a person's normal freedom of movement is pivotal to considering whether an intervention could be a restraint. It is the situation and the scenario that needs taking into account, and no two people's situations are the same, hence whole of life and person-centred assessment are crucial. Peer review could be with a colleague or a clinical advisor. If a person's normal freedom of movement is likely to be restricted, your documentation needs to include the options considered and discounted, the relevant parties involved, and the outcome of their input. Elimination is the goal. However, in some situations, a solution that is a restraint may be required. Elimination is the goal. However, in some situations, a solution that is a restraint may be required. If this is the case, plan a review of the solution at a later date as people's needs do change. This slide has some resources, including the link to the current standard, a Kubro webinar that talks more so to restraint in care facilities. However, I found it really helpful for my understanding of ngā paurewa, and some of the case studies are applicable in other environments as well. The NASC and EMS documents are also referenced there. And for clinical advice, we have included Access-Able's email addresses for the Auckland and Northland regions when equipment is being funded via whaikaha, and our team's whaikaha and ACC funding contact details. So we hope this information has been helpful and thought-provoking, and we are keen to hear your feedback. Feel free to contact our team with any queries or feedback you have. Sarah and I would like to acknowledge Carrie McLean, Krista Rosler, and Shana Lawton Karamina for their input with the presentation. And I'm finishing with a closing karakia. Kia whakaria, te tapu, kia watia ai te ara, kia turiki whakataha ai, kia turiki whakataha ai, homie, hui, taiki.